Hi, everybody. This is Danielle. I'm actually going to be talking to you a little bit tonight about my agency and my field placement. My agency presentation is on the Addiction Center of Broome County, ACBC, and I also am employed at ACBC, so I'm doing quite a bit with the agency right now. So let's start with what we do. We provide outpatient rehabilitation for adults with substance use disorder. We also provide that same service for people with co-occurring disorders. And we really focus on evidence-based, individualized, person-centered care. Our core interventions are motivational interviewing and CBT, a little bit of DBT. We do incorporate that in some of our groups and some of our individuals. So our mission statement really is we want to support long-term sobriety, people's health, and we want to reintegrate people into the community. We have a lot of different departments that are substantially supportive in that mission. We empower all of our clients, all of our patients to rebuild and to heal, and we use this through just showing them empathy and compassion, and like by researching what's going to work best for each individual. We do provide group and individual therapy. We have health homes. We have a harm reduction unit. We have medical. We have life skills development, peer services, peer transportation services, and oh my goodness, we have just about everything. So I want to show you some pictures. Of course, this is the picture of our new building, which we've purchased. Currently, health homes are located there at 15 Charles Street in Binghamton. And right now, our health homes have 1,028 people, clients that are enrolled. So it's very exciting. And this is actually a picture of my office. I absolutely love what I'm doing, and I am working a lot with motivational interviewing. This is obviously collaborative across the board. All of us as clinicians and practitioners use motivational interviewing as a intervention across the board, every department. We ask a lot of open-ended questions. We have a lot of reflective listening, summarization when we're discussing things with clients. And I did research 3 articles, and this article by Smedland in 2011 stated that motivational interviewing improves engagement and reduces substance use. So I thought that was very interesting, and I wanted to make sure that I shared that. We also practice and use daily cognitive behavioral therapy. So a lot of our clients will say things like, I'll never be able to get sober. So we identify those self-defeating thoughts and behaviors, and we try to flip the script. So we basically try to, cognitively retrain that brain, retrain the brain with them to be able to cope, to be able to see things differently, and obviously to prevent cravings and relapse, of course. This really encourages people to solve problems on their own. And I am going to mention an article by McHugh later in my presentation. So in this picture, you'll see one of my coworkers. He actually posed for this. And this is one of our larger group rooms at ACBC. So DBT, this is one of the things that we're touching on. Actually, this is a picture of our hub, the center office, and the young lady posing is our mindfulness, and she's our yoga instructor, sound bath practitioner, and just really holistic clinician, and she uses DBT, and she's trying to incorporate that and really educate us all as clinicians on how we can bring DBT into our practice as well. She has stated many times that it helps clients tolerate distress without relapsing and to communicate their needs effectively. And she, of course, and we're starting to realize this complements our motivational interviewing and CBT interventions for co-occurring disorders as well as substance use disorder. So let's keep going here. This is our medical department, And right now, as far as what we do in tracking, our medical department does a little bit more than our outpatient rehabilitation. They obviously track things like our urine and drug screens and attendance to appointments. Our current tracking for OPR, which is outpatient rehabilitation, is also with attendance. We track that and program graduation. And there was some recommended tools that were given to me by the medical team. So one of the things we're trying to measure is people's self-efficacy and their relapse prevention. So to incorporate validated tools for progress tracking and to strengthen DBT and implement fidelity monitoring and to use feedback loops for quality improvement. So here's what I came up with. To target a variable measure at ACBC, like the length of a person's sobriety, specifically how long a client remains abstinent during and after treatment, we will set goals with the clients, but I think it's important that this progress is tracked through not just attendance, but also through self-report. Future measurement could include first relapse, craving intensity, and coping skills. They could actually give a more comprehensive picture of what we're tracking within the organization. By targeting self-efficacy, we could better evaluate how clients use the skills that we're teaching them, the learned skills, to manage their cravings and prevent their relapses. I think this would be a really good thing to measure so that we could have some more insight into our future long-term sobriety goals. So for my literature reviews, I actually found 3 incredible articles. And these 3 articles were, the first one was by Smedslund in 2011, and they conducted a review. It's the Cochrane Review, and it concluded that motivational interviewing improves engagement and reduces substance use frequency. The standardized measures that they used were, one of those was the readiness to change questionnaire. And that's something that I'm actually going to bring up in supervision at my field placement because I would love to be able to learn how to use that at our organization. The second article that I used for my literature review was by McHugh in 2010. And McHugh found that CBT effectively decreases relapse rates by enhancing the client's ability to challenge their cognitive distortions and thoughts and develop new strategies to cope. And one of the instruments that they included in their measurement and their study was the Beck Depression Inventory for co-occurring symptoms. So again, something I'm going to definitely bring up to our executive director and my supervisor. And lastly, I found an article by Abdel Rahman. It's from 2023, and this article demonstrated and measured that by combining motivational interviewing and cognitive behavioral therapy, it would result in longer abstinence durations, higher self-efficacy, and scores that traditional treatment alone did not reach. So they used obviously urine screens, self-efficacy scales to capture like this behavioral change and this cognitive growth. Very interesting articles. So across these studies, the validity had like different dimensions, and here's what it is: face validity, excuse me. Really, everything clearly measured the substance use and self-efficacy and how they correlate. The content validity, the instruments, they covered the relevant domains such as like coping, motivation, and cravings. The construct validity, really, the scales correlated as expected with relapse and readiness to change. And then the criteria on validity, biological confirmations such as urine tests, validated self-reports. So I think all of these were very reliable and demonstrated that together, all of the instruments that were used in these studies offered a high degree of confidence for outcome measurement in SUD treatment. So ACBC, what I'd like to recommend to them is to adopt some standardized validation tools. I really like to see us using the drug taking confidence questionnaire. That would be incredible. The addiction severity index is currently being used, but not across the board in our agency. I'd like to also implement something called the feedback loop. We currently have every Wednesday we have our case conference, and we discuss high-risk cases that we are all working on, and we bounce ideas off of each other, and then we give what interventions we're going to use, and then we follow up on them the following week. So we have, I think, right now 273 outpatient clients in our clinic, and excuse me, in our outpatient rehabilitation. We have 295 clients in our clinic. So I think a feedback loop with everyone involved would be really huge, where we could share outcome data to identify where the trends are, and really to kind of guide where we need to make adjustments in our programming and treatment programming. I think we can really use this information to personalize our interventions for clients that are struggling with relapse. So if we're measuring more and more effectively, and then we're sharing that in a group with all of the different divisions that we have, I think that could really strengthen how we assist clients for, in person-centered care. And I also think we could include some other things as far as what we could measure. And one of those was emotional regulation. It's not something that we really focus on. We're really focusing on that substance use. But I think a lot of this does have to do with co-occurring disorders, mental health, and I think we need to expand our measurement tools in regards to those factors. And then I really want to see DBT implemented in more areas. I think it needs to be integrated across the board, through all departments. And that will also be something that we can help possibly use to measure that emotional regulation in our patients. So I think if we did these simple things, we could actually enhance our accuracy and depth of outcome measurement, outcome evaluations within the agency. This could help towards people's recovery goals. This could help towards improving interventions. And it really does align with what we're trying to do as evidence-based practice. In conclusion, I do want to add that right now we're really effectively using motivational interviewing and CBT. I'm proud of us. I think we're doing a fine job at the organization, and with so many clients participating, we're keeping it consistent, which is important, especially when people are participating in more than one department. Some people have health homes, and they have the clinic, and they have medical, and they might even have harm reduction. So it's good that we're all using the same theories and methods. I think we are very evidence-based organization, and our management team and our executive director are great leads as far as, hey, let's take a look into that. I mean, everything is not questioned, but delved into. I mean, it's a wonderful place to work because we're always learning. However, the tracking, I can't stop talking about it. It's really just based on attendance and who isn't drinking or using drugs. So I think we can really strengthen this by just introducing different tools and fidelity assessments. I think that by doing so, we could actually really kind of ensure that we have a stronger connection between our theories and the practices that we're doing, and then the outcomes for our clients and our patients. This can only improve quality, and in turn, if quality improves, we're going to see maybe a higher rate of sobriety cases, a higher rate of recovery, which is incredible. So I really think we just need to focus on measuring what truly matters, and some of that has to be about the person, not just the substance use. Um, we're going to continue to build on our incredible mission, and we're going to hopefully help as many individuals as we can in their long-term recovery. So in my last slides, this is our uh, Up Comfort Center where people that are unhoused can stay. And of course, this is our new building. Very excited. Can't wait to live there. And lastly, here are my references and just the back view of our building. It is absolutely gorgeous. And one day we will have, hopefully, we will have inpatient rehabilitation as well and an extended medical team. So my goal at ACBC is to eventually become a mental health practitioner. So we're hoping for that division to be added soon as well. I want to thank you all for listening. I really had a great time learning more about my agency and really delving into our clinical practices. So thanks. Have a great night.